Hello everyone. In today's lesson I will discuss about nasal polyps. Nasal polyps are benign pedunculated tumors formed from edematous, usually chronically inflamed nasal mucosa. They commonly arise from the ethmoidal sinus and occur in the middle meatus. Occasionally they appear within the maxillary antrum and can extend to the nasopharynx, which is called antrochoanal polyp. It is estimated that between 1 to 4% of the population will develop nasal polyps at some point, and the incidence of nasal polyps increase with age. Antrochoanal polyps represent only 4 to 6% of all nasal polyps in general population, but it accounts for approximately 1/3 of polyps in the pediatric population. Large or multiple polyps can completely obstruct the nasal passage, and the polyps originating from the ethmoidal sinus are usually smaller and multiple as compared with the large and usually single anterochoanal polyp. Etiologically, cystic fibrosis is the most common childhood cause of nasal polyposis. Up to 50% of cystic fibrosis patients experience obstructing nasal polyposis, which is rare in non-CF children. Therefore, CF should be suspected in children younger than 12-year-old with nasal polyps, even in the absence of typical respiratory and digestive symptoms. Nasal polyposis is also associated with chronic sinusitis and allergic rhinitis. In the Sumter triad, nasal polyps are associated with aspirin sensitivity and asthma, and this condition is rare in children. Regarding the clinical manifestations of nasal polyps, obstructions of nasal passage is prominent, with associated hyponasal speech and mouth breathing. Profuse unilateral mucoid or mucopurulent rhinorrhea might also be present. On examination of the nasal passage, which shows glistening grape-like masses squeezed between the nasal turbinates and the septum. Examination of the external nose and the rhinoscopy should be performed to diagnose nasal polyps. Ethmoidal polyps can be readily distinguished from the well-vascularized turbinate tissue, which is pink or red, and antrochoanal polyps may have a more fleshy appearance. Antrochoanal polyps may prolapse into the nasopharynx, and in this case, flexible nasopharyngoscope can assist in making the diagnosis. Prolonged presence of ethmoidal polyps in children can widen the bridge of the nose and erode adjacent osseous structures. And tumors of the nose cause more local distraction and distortion of the anatomy, so it can be easily differentiated from nasal polyps. CT scan of the midface is a key to diagnose and planning for surgical treatment. The other is about treatment. Local or systemic decongestants are not usually effective in shrinking the polyps, although they might provide symptomatic relief from the associated mucosal edema. Intranasal steroid sprays and sometimes systemic steroids can provide some shrinkage of nasal polyps with symptomatic relief. Topical nasal steroid spray include fluticasone, mometazone, budesonide appear to result in nasal septum improvement, but we found to have no effect on those with cystic fibrosis. Doxycycline has significant effect on the size of nasal polyps, nasal symptoms, and the mucosal and the systemic markers of inflammation. And polyps should be removed surgically if complete obstruction or uncontrolled rhinorrhea or deformity of the nose appears. If the underlying pathogenic mechanisms can't be eliminated in the case of such as cystic fibrosis, the polyps might soon return even after surgical intervention. Nasal steroid spray should also be started preventively once surgical intervention is done after healing occurs. Antrochoanal polyps do not respond to medical measures and they must be removed surgically, typically via endoscopic sinus surgery. Since these types of polyps are not associated with any underlying disease process, the recurrence rate is much less than for other types of polyps. This is all about nasal polyps. Thank you for watching.